So hello and welcome. I'm Chris Duke with Altarum Institute, and today we're going to be talking about consumer engagement in healthcare. We're going to talk about how we can quantify it with the ACE measure and how we can use engagement to improve patient care. So thank you for being here with us. We're joined today by Dr. Jana Wardian from the Diabetes Center of Excellence at Wilford Hall Medical Center with the U.S. Air Force. Now, just as way of background, I'm a social psychologist and survey methodologist focused on healthcare. I'm also the director of Altarum's consumer engagement programs, and I help develop the ACE measure that we'll be talking about today. Dr. Wardian is a research director at Wilford Hall's Diabetes Center of Excellence and a professor at the Uniformed Services University. So thank you very much for being here with us today, Jana. As Jim said, there is a Q&A box in the middle of your screen on the bottom. Please feel free to ask questions at any time. That will go just to the presenters, so the other audience members won't see that. We'll try to answer questions as they come in if they're topical to what we're talking about. But if you have a more general question, we'll also have dedicated time for questions like that at the end of the webinar. Okay, let's get started. Okay, if you've spent much time going to healthcare conferences or reading the research or talking to folks in healthcare, you've probably heard just how important it is for patients to be involved in their own care. So this is something that we hear again and again, and the research shows it's not just talk, it really is important. And there's a lot of solid research that highlights the benefits of being engaged. So highly engaged patients tend to have safer care. That is to say, they have fewer avoidable complications. Their care tends to be more effective. That is, they receive more benefit from it, while also being less expensive. And we know from research that patients who share in their medical decision-making tend to have better medical adherence and clinical outcomes, on top of reporting higher satisfaction with their care. So there are a lot of benefits that's already kind of pretty well established in the research, and I could go on. But my point is that there's a lot of positive benefit to having highly engaged patients. But despite these findings, and despite all the excitement you'll hear about at the conferences and by talking to other folks, I found there's still a lot of confusion about what consumer or patient engagement actually is. So let's try and break this down just a little bit. Some might say engagement is adherence to medical advice, but the flip side of that if a patient is not fully on board with their care plan, you could say adherence is really compliance rather than engagement. Others might say engagement is better self-care and chronic disease management. And while that's definitely part of it, I'm not sure it's the whole picture all by itself. A health IT advocate might say engagement is using the patient portal. And that's a good thing, but again, it's a very narrow slice of what healthcare is. And where does shared decision-making fit in? What about patients engaging in consumerism by comparing cost and quality? Are those things engagement? I think most of us here would say that engagement can be all of those things. But if you were to ask someone what it is, they may not name those things specifically. So I think there's not really a consensus in the field about what we mean when we say the words consumer engagement. I think this confusion about what consumer engagement means is actually a significant problem to advancing research that tries to better understand engagement or use strategies to try and boost or otherwise use consumer engagement. I mean, if we mean slightly different things when we're talking about engagement, how are we able to effectively communicate with each other? If what I'm thinking of is successful chronic disease management, while you're thinking of engagement as consumers comparing prices to get a better deal. And if we don't agree on exactly what we mean, how would we then go about measuring it in a systematic way? And if we can't measure it, how would we use it strategically? So I think this confusion has been a real vulnerability in advancing patient care. So several years ago, maybe around 2012, a group of us at Altarum decided that we wanted to do something about this. We wanted to create an evidence-based measure of consumer engagement that would be free for anyone to use. So this is something that providers and researchers could use to research the benefits of engagement and develop strategies for improving patient care. So we set out to do exactly that. Okay. So once we decided that we wanted to create a measure of patient engagement, we started to talk about our priorities for filling in the gaps left by other tools. So there are plenty of tools out there, but we found that they all have some kind of limitation or another, and we wanted to address as many of those as we could. So first, we wanted our measure to be grounded in good science. We wanted to use the best methods available to create something that was evidence-based with strong predictive power of real-world outcomes. Second, we wanted our tool to be licensable at no financial cost. But as we talked to more and more people, we kept hearing from folks, especially at nonprofits, who wanted to use some of the existing tools, but were limited by the high licensing fees. So some of the tools that are out there can cost $1 or $2 per usage per patient, and that's for you to do all the work, just to use their survey. And that kind of price can add up quickly. For a large hospital, that can be more than $1 million a year. And even a small clinic can be on the hook for thousands of dollars, which, frankly, they could probably find a better use for. So we saw this as a real limitation to the field, and we wanted to avoid putting people in that kind of financial bind. So we decided that our measure would cost no money to license. Third, healthcare is changing very rapidly, and with the rise of the internet, consumerism, comparison tools, and high-deductible health plans, things are a lot different than they used to be. So we wanted to make sure that our measure included more modern items that maybe didn't make it into tools that were developed 10 or 15 years ago. Finally, we wanted to take a broad scope in how we defined engagement. Some of the other tools out there define engagement as a single metric that you can be high or low on. And we felt that healthcare engagement is a little bit more complex than that. There are a lot of different moving parts in healthcare, and people can be good at some things, like, for example, learning about health, and disengage with other things, like knowing how to actually use their benefits. So, this is a broad thing. It's more than just using a portal or going online. It's more than being a savvy consumer. So we wanted our measure to be broad and multidimensional, incorporating the different elements of being a modern healthcare consumer. So with a clear idea in mind, we talked to Kent Bradley at Safeway Health, and they agreed to fund the development of the Altarum Consumer Engagement Measure. Okay. All right, so where do you start when you are trying to define something as broad as consumer engagement? Well, we started with the National Center for Advancing Health's definition, which they define as actions individuals must take to obtain the greatest benefit from the healthcare services available to them. And they've created this thing called the Engagement Behavior Framework, and it goes on to define 10 broad domains of engagement. These are things like communicating with providers, making good treatment decisions, and seeking health knowledge. So as a first step, we convened a panel of experts to get their feedback and add their ideas to the Engagement Behavior Framework. And from this collection of ideas, we developed more than 100 candidate survey questions. So these are short questions that touched on every single aspect of engagement that we could think of in many different ways. So once we had our candidate questions, we fielded them across several surveys to more than 10,000 healthcare consumers. In addition to our candidate questions, we also fielded a battery of health outcomes and behavior questions like health status, self-care, and making comparisons. Now we did this so we could better understand how our test questions could relate to the actual outcomes. For example, one of our test groups was a sample of just over 2,000 Safeway employees, and we were able to associate their actual clinical data from their HRA to their survey scores. I want to emphasize this was all completely de-identified and anonymized, and we didn't know who these people were. But by having clinical data next to survey data, we could really understand how our survey questions predicted real clinical outcomes. So we tested more than 100 candidate questions on more than 10,000 people across 4 different sample groups. And then finally, we used a series of psychometric techniques, including principal components analysis and Roche analysis, to find how clusters of questions represent specific concepts of engagement. So how does a group of questions map on to a specific pattern of behavior? These are statistical techniques that are able to boil down all of these questions down to just a few domains with just a few questions on each domain. So in our case, we were able to reduce these 100 items to a short tool with 3 domains of engagement with just 4 questions on each domain. So that's 12 questions total. And this short tool is what became the ACE measure. Okay, so you may be wondering, what do I mean by a domain? A domain is just a group of similar questions that people tend to answer in the same way. So we call the 3 domains on ACE commitment, informed choice, and navigation. Commitment in this case refers to everyday health behaviors like diet and exercise and self-care. It's highly predictive of health outcomes. We'll talk a little bit more about this in a minute. Next is informed choice. This refers to a consumer's preference for learning about health, choosing their providers carefully, and engaging in shared decision-making. Finally, we have navigation. This is a patient's skill and experience navigating the healthcare system. We find it's quite predictive of being able to use benefits effectively in engaging in price and quality comparisons. So the way ACE works with these domains is that everyone gets a score on each domain, and the total ACE score is the sum of all the domains together. So you have both a domain score and a total score. I do want to point out that the domains are correlated, meaning if you're high in one, you're likely to be high in another, but you don't have to be. They are independent. For example, someone can be committed to diet and exercise, but not have a clue as to how to make an appointment or use their benefits. So we find that a fair number of young people kind of fall into this category. They're into health, but they don't know how to use healthcare. And obviously that presents a unique set of challenges for them as patients. I do want to emphasize that we did not pick these domains because we thought they were important, because that would introduce our own bias. We didn't decide that what we thought should count. By using the statistical techniques that we did, we let the data tell us which domains were most important. And likewise, on those domains, which specific questions captured the most predictive power for each domain. Okay, so I'd like to talk a little bit about each individual domain, a little bit more depth. So the first is commitment. Like we said, these are the everyday health behaviors. And these are things like diet, exercise, self-care, adherence. We find that these are very, very highly predictive of self-care success for people with chronic disease and health outcomes. If you are familiar with the patient activation measure, this has a fairly strong correlation with PAM. It's about 0.64, which tends to be about as high as you find across 2 different survey measures. So if you're familiar with that, this kind of puts you in the frame of mind for what kind of psychometric concept this is measuring. The kind of questions this includes are things like, I can stick with plans to exercise and eat a healthy diet, and when I work to improve my health, I succeed. So you can see the 4 questions there. So pretty simple, pretty straightforward. It's a measure of people's overall sense of commitment to these daily behaviors. And by using the Safeway data and other data, we found that this actually has an incredible relationship with real biometric health outcomes. So as a part of the Safeway data, we were able to collect many things, including BMI. So looking at about 1,800 patients, we found this incredibly strong a relationship between commitment and BMI. So in this chart here, I've split commitment up into 4 equal groups, going from the lowest scores to the highest scores. So they're all roughly equal in their size. And among those who are in the lowest commitment group, you'll see that 54% were clinically obese, while in the highest commitment group, only 15% were. So that's really an enormous difference to go from 54 to 15 just across 4 equal groups. It's fairly high predictive power for only 4 questions. This is 4 equal groups here, but if we expand it even more, looking into fewer groups or looking at the highest and lowest scores, you'll actually find that those with the lowest scores of all, 90%, are clinically obese, whereas the highest score, only 10% are. So really very, very strongly predictive of people's actual health status. Next, we have informed choice. And this is something that we really don't see on other tools that aim to measure patient engagement. It's kind of a relatively newer concept psychometrically. And this is people's desire to seek and use health information. So we're measuring people's desire to learn about health, how they choose their providers, and their interest in shared decision-making. So the kind of questions that this would include is when choosing a new doctor, I look for official ratings based on patient health, and I spend a lot of time learning about health and things along those lines. When we look at this by how people seek information out, in surveys we frame this a few different ways, but in this particular case, we ask people that when they think they need to see a doctor, do they prefer to learn about it beforehand and try and educate themselves, learn about the health condition, or do they just go in and ask the doctor to kind of tell them what's going on? So are they going to learn about it first or rely on the doctor to tell them? And we find that for those who are low on informed choice, and in this case it's just kind of a 50-50 split, so just 2 groups. Those who are low on informed choice, 29% seek out information on their own beforehand, whereas those who are high in informed choice, almost 8 out of 10, 79%, are seeking out information. So this really represents 2 completely different paradigms for how people are seeking for information and whether they want to seek it out themselves or really rely on it to be given to them. Finally, we have navigation. This is someone's skill and savvy at using the healthcare system. You can be very interested in your personal health, but really have no clue how to actually interact with our very complex healthcare system. And this is a skill that needs to be cultivated to really get the most value out of what our system, our imperfect system, can provide. So we find that this is highly predictive of someone's need for a healthcare navigator, and their history of using comparison tools to get the best cost or quality out of the care they're seeking. So these kinds of questions would include things like, I have lots of experience using the healthcare system, and I feel comfortable talking to my doctor about my health. So again, looking at some results by navigation, we split this out 2 ways into low and high navigation. And what we're looking at here is whether people have reported in the past 12 months, did they ask about the price of care prior to actually receiving care? You know, it's one thing to ask about the bill after you get it, but if you ask about the price beforehand, you can help make an informed decision and lower your out-of-pocket costs. So we found that among those high on navigation, 58% reported asking about the price of a healthcare service in the past 12 months, compared to just 25% for those low on navigation. So you're more than twice as likely to ask about the price beforehand if you are higher on navigation. So really, this is something that can potentially tell you a lot about what someone's healthcare costs are likely to be and how savvy they are as a consumer. Okay, so now we've covered the 3 domains of ACE, and you might be wondering, okay, well, how do we actually use it? So I'd like to cover 3 different use cases for how people have used ACE. The first is predicting health outcomes. So we just covered a few minutes ago how the commitment domain is highly predictive of health status. This has a number of possible ramifications for how we care for patients. Dr. Wardian will be talking to us more about this in just a moment in a study we did with the Diabetes Center of Excellence. Another use case we're going to talk about after Dr. Wardian speaks is using ACE to test the effectiveness of health promotion or engagement promotion interventions. And we spend so much time and money on efforts to boost engagement, but we spend relatively little time measuring the effectiveness of these interventions. So ACE allows us to understand if we did actually, quote, move the needle for engagement. And finally, we'll talk about tailored messaging based on engagement. This is based on the idea that patients start at different levels, and the ways that we communicate with them will be more successful if we meet them where they are now rather than force a one-size-fits-all approach. So this can include tailoring patient goals to be achievable and giving them the resources so that they can make the most of it. But before we get into those, we'll start with our study of ACE in diabetics at the Diabetic Center of Excellence. Jana, do you want to take it from here?
Sure. Thank you so much for allowing me to come and speak about our experience with the Altarum measure, ACE, and commitment specifically. I am the research director here, and I want to acknowledge our partners. We recently had a paper that was a product of this partnership, and Dr. Danielle Bersabe here, who's in internal medicine, was on that paper, as well as the director of the center, Tom Sauerwein. And of course, Chris. Chris did all of the statistical analysis for us, and we're very appreciative of that. Anytime that I speak, I need to acknowledge that the views expressed are those of the presenter, me, and do not reflect the official views or policies of the Department of Defense or its components. So I've gotten that out of the way. Now let me talk a little bit about the research study design. So, our research goal was to understand the relationship between patient commitment and A1C and BMI in a military diabetes clinic. We are a specialty clinic where we see patients that have particularly complex disease processes, and they're generally much farther along in their time with a diabetes diagnosis. We see all patients with type 1 diabetes. However, our survey was only distributed to patients who had type 2 diabetes and were adults and had been a patient at our clinic for at least a year, and you'll see why that's important in a moment. So the patients were invited to complete a 15-minute survey, and we had 273 patients that agreed to do that and took part in the survey in our clinic. Health outcomes were including A1C, which is a measure of how their blood sugar is managed over about 3 months and is highly predictive of complications down the road, and BMI, abstracted from prior clinical visits. So we had access to our electronic health record, and we actually did a look back. So we looked back over the past year and could see how their A1C trended over the past few times that they had been in our clinic and had their labs drawn. So the research coordinator identified those patients, and we have what we call study tags, that we identified them and pulled them into the study that way. Our providers were very helpful. I need to acknowledge also that we have a really supportive environment for research here. So when we looked at the ACE commitment, one of the things you need to know is that we looked at 6 items. Well, the ACE measure has been reduced to 12 items and 4 in the commitment domain. The entire 21-item ACE was administered at that time. But we found that the 6 questions in the commitment measure were associated with HbA1c or A1c. Here are the 6 questions that we used so that you can get an idea. There are a couple of additional ones. And remember, the response choices included 1, on the low end, strongly disagree with this statement, all the way up to 5, I strongly agree with that statement. So we added just a couple. You'll see question 5 and 6. I take responsibility for managing my health, and I take an active role in my own health care were included in this measure as well. So you can see that the really nice bell curve distribution of all the scores is evident. About 1/4 of patients scored as having low commitment, which is scored as less than 16 on this measure. And the total range is 0 to 25. So if they had less than 16, they were in the low commitment, or the red box here. Another quarter had high commitment, which is greater than 22 out of 25, as seen in the green. So most patients scored as moderate commitment, as seen in the orange in the middle. And again, we can take another look at the commitment measure and its relationship with self-reported health status. So you can see that the bell curves were seen in the good health category right in the middle, but look very, very different on either extreme. Poor and fair health were associated with low commitment. Much higher rates of low commitment there, 15% in the poor and 28% in the fair category. And good, very good or excellent health were associated with high commitment. So you can see 48% who said they had very good health also had high commitment. And in the excellent category, 8%, which is more than double the moderate and 8 times the lowest group, said that they had high commitment to their health. So now let's take a look at A1C, the percent with well-managed A1C. We consider well-managed A1C to be below 7%. So remember that we did a look back over the past 8 months. So each time point here represents about 4 months prior to the survey on the far right side, and then prior again to that middle value of A1C. So there are 3 time points here, and they're over 4 months separating each of the time points approximately. So patients with an A1C of less than 7 were far more likely to have high commitment to their health over time. You can see that it just became better and better and better with those who had high commitment at the farthest time point. And then you can also see that there's a striking difference in commitment with patients who were significantly more likely to reach the goal of HbA1c over time. So you can see how important their personal commitment is to reaching their blood sugar goals. And now, we can't actually say from the way we constructed this study that it's predictive, it's associated. We don't know which came first. Did they start seeing positive results in their A1C and so they became more committed, or did their commitment result in better A1C? Also, I just want to mention that all of these patients were at the Diabetes Center of Excellence for a year. So I think that's important to keep in mind that they've been in our care. They may have had sort of a low commitment at first, and we'd like to believe that we fostered a bit of a higher commitment over time as they began to have confidence in their care here. We have another measure called the Diabetes Distress Scale, and we find that DCOE patients have very low physician-related distress because they have confidence in their health care here. So now let's take a look at the percent of people with A1Cs of greater than or equal to 9% over time. We consider that to be poor control or poor management of their A1C or their blood sugar. So the opposite is true for people with high A1C. Patients with A1Cs of 9% or greater were more likely to have low commitment to their health. In fact, more than twice as likely. So there is this really interesting relationship with management of blood sugar over time. So what does this mean? Clearly there's that relationship between commitment and blood sugar management. But which comes first? As I said, we can't really be sure which predicts which, so we need more studies in order to understand that. Next, we're going to be looking at commitment and engagement in a year-long health program. And I included for you sort of our reference there for the paper that we just recently got published, and it was actually published online. You can take a look at it there. And I think I'm going to toss the ball back to you, Chris.
All right. So great. Thank you so much, Jana. I really appreciate that review. So that was looking at how the commitment scale can be used to understand someone's likely health status. As Jana mentioned, we can't indicate causality. We can predict in the non-causal sense, but we can't say that one caused another one yet. But that's kind of next in line for our research goals. It certainly has space validity, but we would need to do an experiment where we move engagement, and then see health outcomes follow. We have a few of those kind of lined up, but they take some time to do. So let's move on to another use case, which is evaluating health interventions. And this is kind of related to how we could get a better idea of how we could show causality. So the healthcare community spends billions of dollars every year trying to promote health and patient engagement. This doesn't just include providers and insurers, but it also includes employers, the government, third-party organizations as well. But despite this enormous effort, far less effort is spent asking if any of these campaigns actually work. The recent research, which you may have seen, has found that many employer-sponsored health programs, such as incentives for meeting certain goals, don't actually work very well. I don't mean to say that they can't work, just that often the way they're put into practice, they don't. And even if a program does work well, you don't necessarily know if it works unless it was evaluated properly. And many of these programs are never formally tested. But because ACE is a measurement tool, it can act as a way of formally measuring if these programs are actually improving patient engagement. Now you might ask, well, why not just measure the actual health outcomes themselves, since presumably that's what you're really concerned about. And while health outcomes are very, very important, they can take a long time to show up in a population, possibly several years. And they can be much more expensive to measure because often they need to be measured in a clinical context. Because we know commitment is a good proxy for health, we can infer likely health status and health trajectory from the commitment score. Having to type my password in because my computer went to sleep. Okay, we're back. Okay, so let's take an example of evaluating interventions. So let's say a hospital is piloting a new diabetes program. And in this case, patients are randomly assigned to one of three groups. So let's say they either get text and email reminders about self-care. We can call that the e-reminder group. Another group is put into small peer groups that meet once a week to discuss diabetes self-management. Finally, there's a control group that gets no special intervention. And let's say the hospital runs this program for 2 years, measuring ACE commitment at the beginning and then again every 6 months. They're also collecting A1c and other health outcomes as well. So this will effectively allow us to understand the effect of each program on boosting commitment, and likewise, how that might impact the actual health outcomes. So I hope that's clear. That's 3 conditions, either e-reminders, small group discussion, or control. And we're going to measure ACE and health outcomes every 6 months for 2 years. So let's look at some hypothetical results of what this might actually look like. So again, these are not real results. They're hypothetical. We're working on studies similar to this, but they're not complete yet. So what we see here are longitudinal trend lines split out by condition. So in these trend lines, the gray line is the control, the pink line would be the e-reminder, and the red line would be the small groups. On the left, we have the ACE commitment score over time, and on the right, we have A1c. So we could see at the start of the study, where it says 0 months, all 3 groups start at about the same place. That is to say, their commitment scores are all about the same. Likewise, their A1c scores are about the same. But over time, at each 6-month interval, you'll see these scores start to diverge. The control group doesn't do much of anything, which is what we would expect because they're not getting any different treatment. And you'll see the e-reminders group makes a little bit of progress and starts to break out from the control group. But again, this is not a big difference. The small group discussion condition really makes some progress, though. So you can see the red line clearly breaking away from the others as they increase their commitment. That is how we're measuring patient engagement over time. Likewise, we can see their A1c dropping to a healthier level on the right side of the chart. In this example, the people in the small group discussion condition are making significant improvements to both their engagement and their health outcomes over time. The e-reminders group made some improvement, but it was more modest. And the control, of course, stayed as they were. And if we were doing this as a real study, we could use something like mediated regression to try and indicate causality here, that it's the engagement that's helping to contribute to these improvements. But this kind of design would be a way for you to test health promotion campaigns or interventions head-to-head, so you can see what works best. And the way you do this, as we've shown here, would be to measure ACE and health outcomes over time and across conditions, so you can see how they compare. So if you have an intervention you want to implement, this can really help you understand what your impact is and whether it's worth scaling up to a larger group. Okay, so evaluating an intervention is a second use case. Let's talk about a third use case, which is tailoring how we talk to patients. So we probably intuitively know that patients start at different levels when it comes to their experience and engagement, both with their own health and their health care. But a lot of our messaging from the healthcare system to patients takes a one-size-fits-all approach. That is, a whole population of patients will get the same kind of message and possibly similar health goals and resources. But because patients have all different levels of engagement and abilities, that may not be the most effective approach. For example, if we're trying to encourage exercise, we wouldn't ask someone with limited mobility to take the stairs because it might be inappropriately challenging. Likewise, it would be silly to ask a marathon runner to take the stairs because that goal would be too easy. You want to find the right fit that's not too hard and not too easy. By understanding where a patient is in terms of their engagement level, we can better understand how to target that patient's goals. Likewise, there may be language that is more compelling at different engagement levels. So what I mean by that is that someone who scores fairly low might benefit from a more motivational message that's sympathetic to where they are. Whereas someone who scores fairly high, they may not need that pep talk. They might benefit more from a kind of a straight-to-the-point approach that focuses on the practical things that they can do. Finally, we can recommend different kinds of resources to patients based on their scores. So some people may need simpler resources that use more plain language. Others might be ready for something a little bit more advanced. So by putting patients in these different kinds of buckets, we can tailor how we talk to them to make our message more accessible. So let's take an example here. Let's say a health plan wants to tailor their communications for their beneficiaries to promote using a price comparison tool to try and lower the cost of care. So in this case, the ACE domain of most interest would be navigation. We've talked a lot about commitment, which relates to your sort of standard health behaviors, but navigation relates to sort of someone's skill and savvy in using the healthcare system and figuring out better prices. So in this example, they know the beneficiary's ACE score from the HRA, and they also have a general indicator of overall health status. So by sort of looking at these two things together, ACE and the health status, this would put beneficiaries into one of four buckets. That is, they can be low on engagement and poor health, shown here on bottom left, low on engagement and good health, which you see top left, high engagement poor health would be bottom right, and high engagement good health would be top right. But as you can see in this chart, this lays out the different kinds of messaging styles, goals, and resources that we might give to each quadrant of the beneficiaries. So those who are less engaged would get more sympathetic and motivating messages. Those who are highly engaged might get more practical messages. The idea being that someone could move across these quadrants over time. Not necessarily stuck there, it's just kind of where you are at that moment. And again, how we would message to people may also vary by health status. The idea is that everyone gets a message that resonates most with them, presents them the most achievable goals, and resources that they are able to get the most use out of. So what would results look like for a study like this? Again, although we are implementing studies similar to this, these results are hypothetical because those studies are still ongoing. In this example, we might compare a one-size-fits-all approach to communications with the tailored communications that we were just talking about. The primary outcome in this case is if the beneficiary used the price comparison tool or not. So in this example, we might see that tailored communications were more successful than untailored. That is, the set of bars on the right are higher than the set of bars on the left. And additionally, those who are more engaged, who score higher on navigation in this case, are also more likely to use the price comparison tool. So that means within each set, the right-hand bar, the darker red, is higher than the left-hand bar. But even though we have these differences between low and high, the tailored messaging helps both types of people increase their uptake. So again, this is just an example to demonstrate how this kind of approach would work. We're currently working on research for this, and we'll be excited to present that at a future date. Okay, so those are 3 use cases that we kind of see the most interest in with our research partners. But I want to talk about some other possibilities as well that we've also seen our partners using. One is population benchmarking. So there are a lot of provider networks or health plans that deal with a more unique kind of set of patients. Maybe they're lower income, or they have some unique factor about them. Maybe they're a Medicare population, Medicaid population. And they want to kind of understand how their needs tend to differ from the national averages. So we have national average scores for ACE. And if ACE is applied to a special population, we can compare those to the national benchmarks and begin to extrapolate the kinds of differences that we might see for their needs compared to the national level. So this would allow a group of providers or a health plan to kind of understand a little bit about their population before they actually start seeing them. Another example is patient reports. So in this use case, we had a hospital system doing this. The patient takes the ACE measure on a tablet in the waiting room, and as soon as they're done, it sends that message, those results to the provider, and the provider is then able to review the results with that patient in the provider's office. So they can discuss the concept of engagement, where they're likely to do especially well, where they might be more likely to face challenges, and then provide a printout of that report to the patient for that patient to take home with them. And then the next time they come, they can get another report, and they can track that over time. A third use case on this slide that we've seen people using this for ACE is triaging scarce resources. So we often have something that we can give to patients in need to help them out a little bit more. So that might be a healthcare navigator or a health coach, being enrolled in a small group discussion, like we talked about. But we don't necessarily know who to give those special things to. ACE is something that could potentially allow you to understand who would benefit the most from that. So if someone scores especially low on navigation, you might offer them a navigator. If someone scores especially low on commitment, you might offer them a health coach to help motivate them or understand what their concerns are. So this is a way of directing resources to the people who could benefit from them the most. Fourth example is course of treatment. We have 2 or 3 studies ongoing on this right now, but this is the idea that because high commitment patients tend to be better at rigorous self-care, the kind of treatment you recommend to a patient may vary based on how much self-care is required. So for example, if you have a surgical procedure that requires the patient to be very, very rigorous in the follow-up care afterwards, that might be a good fit for a high commitment patient. But someone who is lower on commitment, that may not be the best choice because they may not be able to accurately and consistently follow through with the self-care they need to make that a success. So I would never recommend this be used to approve or deny people care, but it may be something that can serve as the basis for a realistic conversation with the patient about their ability to follow through. So like I said, we have 3 studies currently using this in different contexts, and we look forward to publishing those soon. And the final use case is health coaching. So this is the idea that when health coaches have the ACE scores, they can better understand where their patient is and kind of talk to them at their level. So this is really kind of a similar idea to tailored messaging, but more conversational and interpersonal. So if you understand someone is pretty low, you can help them out and maybe focus more on motivation and encouragement. Where someone is already very capable, maybe they don't need that. So these are five different kinds of use cases that we didn't have the time for to explore fully, but we have partners that are using them and exploring them and think they're of value. So if you are interested in using ACE, one thing I want to make clear is that there is no financial cost. We do ask for de-identified data sharing to help advance our research. But we can certainly work with you on that if that's something that's going to be problematic. We're happy to discuss your research ideas with you for free to ensure a sound implementation. But if you think you might need a more advanced level of support, we do provide that through consultation and survey fielding services, although that's certainly by no means required. You can learn more by going to our webpage for this, which is listed there below. It's altarum.org/our-work/ACE Measure. Okay, at that point, that is the end of our presentation. If anyone has any questions or comments, please feel free to put them in the Q&A box. If it's for a particular one of us, either Jana or myself, you can indicate that, or we can just take them as they come. You're also welcome to email me directly if you'd like, if you have questions that way. And after the session is done, please click on the link to complete the post-webinar evaluation. Your thoughtful input will help us make these better. And as a final reminder, these slides are available for download. They're in the resources pod on the bottom right side of your screen. And the floor is open for questions. Okay, none yet. I'll leave it open a little bit longer in case anyone has any. Jana, while we're waiting, do you have any final comments or thoughts you'd like to add?
I guess I just wanted to let everyone know we will be doing another study with Altarum. We're looking at this health intervention, and we're going to measure it over time. So we're going to include those 4 commitment questions at baseline, 3 months, 6, 9, and 12 months. So we'll see what happens over time and how commitment is related to health outcomes in a variety of ways, as well as psychosocial measures. So we're looking forward to partnering again.
Great. And I had one comment come in. Says someone could not download the slides. I just tried to download them and found it to be successful. If you have trouble and you would like a copy, please just email me at chris.duke@altarum.org, and we'll be sure to send you a copy. Okay. Well, I think that probably wraps it up. Jim, do you have any final comments?
No, I would just like to let everyone know that a copy of today's slide presentation in PDF format will be emailed to everyone who registered for today's webinar. That's it, Chris.
Very good. Thank you so much. Thank you for joining us today. Hope it was helpful.